medic, and one, put in 12 lead on. Placement is key. If you put them on poorly, you're going to get a poor reading of ECG. So if you put them on correctly, you're going to get a good reading of ECG. So placement's important. I know a lot of medics rely on their EMTs to put it on properly. Secondly, if you looked at something, maybe, you know, medic was busy and you pulled it out and you'd be like, wow, I remember Felix mentioning XYZ and I see that right here. Just bring it to the medic's attention. And sometimes something as simple as that can make the world of a difference when it comes to patient outcome. So I'm not here to talk about, I'm not going to take you back to the beginning of electrophysiology and how EKGs came about and take you from the nuts and bolts. We'll be here for 3 days. So what I'm going to talk about is the meat and potatoes about 12 lead, what we really need to know when we're out there doing 12 leads. I'm going to give you some simple ways to remember things. So when you see that 12 lead, it sticks with you long term, okay? So once again, my name is Felix. I'm from Orlando Medical Institute. Will asked me, can I come out and do this class? Like I said, I did it for Orange County for their preceptorship class that they were doing. I was able to do a few of those. And something I'm very passionate about is actually ECGs and 12 leads. So I want to start with a little bit of electrophysiology. I'm going to get into it, just the meat and potatoes, as I mentioned. So electrophysiology is very, very important. We need to understand, how does it work? How does the heart work? It has its own electrical impulses. The heart has what we refer to as automaticity, has the ability to generate its own electrical impulse with the use of electrolytes such as sodium, potassium, calcium. The fluctuation of those electrolytes stimulates the heart to beat in its own. So if I came here and I ripped his heart out, it will still beat. Obviously it will die because I disconnected from its source of energy and oxygen, okay? Well, one thing I want to start with and let you guys know, when we talk about the human body, by the way, I am an artist. I told the guys early, they probably agree on that I am an artist, so I get to draw. I draw very well, all right? So when we talk about the human body, I'm an abstract artist, but an artist is an artist. The human body, the musculoskeletal system, uses a 6-to-1 ratio. 6 molecules of oxygen for every 1 molecule of glucose. If your body can formulate that consistently, your body can perfuse every single cell, tissue, organ of the body, of the musculoskeletal system. That's the ratio, all right? The heart uses a 17-to-1. The heart actually uses 17 molecules of oxygen for every 1 fatty acid. The heart doesn't use glucose as a source of energy. The only heart that still uses glucose as a source of energy is small children. Adults use fatty acid. That's why if you look at your H's and T's, when we talk about treatable causes, hypoglycemia is not a treatable cause on the adult patient because it's not what the heart uses as a source of energy. But if you look at PALS and pediatrics, hypoglycemic is back in there. Why? Because small kids still use glucose as a source of energy. So we use fatty acid. We use a 17-to-1. So you can see the heart versus the body, the musculoskeletal system, the heart consumes almost 3 times more oxygen than any other muscle in your body. So the heart's the diva, all right? So the heart, if you're hypoxic, what's the first organ that's going to suffer? The organ that consumes the most oxygen. What organ is that? The heart. That's why they say when a patient's hypoxic, ischemia, myocardial ischemia sets in within 1 minute of being hypoxic. Why? Because it consumes so much oxygen. Everybody with me so far? All right. So back to the electrophysiology. We have what's called an axis. Oh, apologize. What we have is called an axis. We need to identify vectors and axes. What is a vector? A vector is each one of those arrows of my picture is a vector. Anytime you have a vector, it's energy trying to move towards the positive, all right? Electrons trying to move from the negative to the positive. That's what a vector is doing. The more direct I go towards the positive, the stronger the contractility would be because the stronger electricity is, okay? The more I vector away, let me just make a bigger picture here so you guys can see what I'm talking about. The more direct I go, the stronger the deflection will be, the stronger the contractility would be. And this is the imaginary line that separates negative from positive. Am I still moving towards the positive? Am I on the side of the positive? Yes, right? Am I moving directly? No. But because I'm on the positive, my deflection is still going to be upright, but not as strong. How about this arrow? Am I still on the side of the positive? Yes, right? But I'm not going as direct. My deflection will still be upright, but not as strong. Vice versa. If I move directly towards the negative, my deflection is going to be downwards and very strong. If I'm still on the negative side, not going direct, not as strong. Everybody with me so far? We always want to move towards the positive. Once again, why? That's the stronger the contractility would be. All right? So that's the key right here. We want to move. We say we want to move towards what we call hypertrophy. Move towards hypertrophy, moving towards the positive. So each one of those arrows represents a vector. Why are they going in different directions? Because the heart doesn't contract like this. The heart contracts like this. So the vectors are moving differently to get the most of that myocardium to contract with its maximum amount of force possible. So if you look at the area, let's talk about all these vectors. Shoot. All these vectors right here. That's the left ventricle. So all those vectors are working together to make that left ventricle contract with its maximum amount of force. Everybody with me? All those vectors working together right here, we refer to that as an axis. So vectors working together, a bunch of vectors working together gives us our axis. All right? And if I'm moving constantly towards that positive directly, then my contractility is going to be what? Strong, right? You guys can answer. It's okay. It's interactive, you know. At least one person. All right? Make me feel like you're picking up what I'm putting down. So why is access important? Because when we get into talking about after electrophysiology and we get into disease process, you're going to learn anytime muscle dies, I can't move towards it. So I have to deviate. I have to go around the dead tissue. So if I go around the dead tissue, am I going directly the way I used to go? No. So what happens to the strength of contractility? It decreases. And when that decreases, we decrease cardiac output. We decrease cardiac output, we decrease blood flow. We decrease giving the oxygen and nutrients that the heart and every other organ needs. So that's why electrophysiology is so important. So when we talk about access, we use two leads. All right? So we're going to view from two leads. We're going to look at the two leads that actually split 360 degrees into four circles. So we look at the heart from a 360 degree angle. Everybody with me so far? Anybody know what lead looks directly across? Anybody know what leads look directly across this way? All right, close. One. Lead one. This is lead one. I'll actually show you the lead. Let's draw the heart here. That's lead one. This is lead two. This is lead three. This is AVF, which stands for augmentum vectoring towards the foot. This is augmentum vectoring towards the left. This is augmentum vectoring towards the right. Everybody with me so far? All right, so those are what we call our limb leads, also known as augmentum leads, unipolar, bipolar leads. That's it. Then right here, you have what's called the Wilson's central terminal. Have you ever heard of that before? The Wilson central terminal. That's how electrophysiology works. When you put the monitor on, it uses that Wilson central terminal. So that's at the center of the heart. And then the electricity moves towards that lead of the way it's vectoring in. So I start at the Wilson's terminal, and that's where I'm looking. So if I start from here and go down, what lead is that? AVF. If I'm going this way, 2. That's why we use lead 2 as our single lead. Why? Because it uses the pathway of the conduction system. So it's the best lead to read an ECG. So lead 2. Then the opposite, lead 3, 1, AVL, AVF. Everybody with me so far? So this one goes this way. So from the Wilson central terminal, if I go this way towards lead 1, am I moving towards the positive? Absolutely. So guess what it's here? Positive, right? So if this is positive, where's the negative? The opposite side. So if I went from the Wilson Central Terminal this way, I'm looking towards the negative. You with me? So did that cut that in half? Top to bottom, right? What's the other lead that would cut left to right? Directly. AVF. So if I go from the Wilson Central Terminal down, what's this right here? Positive or negative? So that means this is what? Negative. Everybody with me so far? I'm going to erase the other stuff because I want to make it like a pie. Or 4 quadrants, I should say, not a pie. Big slices, right? We're hungry. All right. So what are the 2 leads that split into 4 quadrants? We'll call this quadrant 1. We'll call this quadrant 2, quadrant 3, quadrant 4. Lead 1 in AVF, right? Everybody with me? All right. So we know the heart don't sit in the center of the chest, right? It sits slightly to the left and a little lower than up when we refer to the anatomy of the thoracic cavity. So our heart actually sits like right here. So what quadrant does our heart sit in? 4. A little bit in 3, a little bit in 2, but mainly 4. Everybody with me? So this is where my heart sits, quadrant 4. So we have lead 1, AVF, right? So if I'm using this should be what? Positive, right? What degree is this? 90. So we put 90 right here. If I'm moving towards the positive, what kind of 90 would that be? A positive or negative 90? Positive, very good. So if that's 90, what degree is this? 0. So if you rough rule normal access, 90 to 0. 0, positive 90. If my access is between 0 and positive 90, that's normal access. What is that telling me? That my electricity is moving directly towards the positive the way it should. Normal access. Everybody with me so far? All right. So if I used just this one, this is lead 1, right? Lead 1. This lead right here, I take this away. Lead 1, I separate top to bottom. Everybody with me? So this is an imaginary line. Why I need imaginary line? Because everything on this side of the line is going to be what? Everything on this side of the line is going to be what? Negative, right? So if I'm moving directly to lead 1, that's lead 1, my deflection should be upwards or downwards? Upwards, because I'm moving towards the what? Very good. How about here? I'm still on the positive side, so my deflection would still be what? Upward. How about if I was going this way? Downwards. All right. You're picking up what I'm putting down. I know you say, Felix, where you getting at? I'll get there. I just want to make pieces. I like to say my 12 leads like a big puzzle. I'm going to give you a piece every time I speak. If you're picking up what I'm putting down, you got the big picture. So if I decided to use the other lead, AVF, that goes this way, then which way is my imaginary line? So everything above here, all right, so let's go. So this is AVF. Everything down here is positive. Everything up here is what? So if I did the imaginary line, all this is what? All this is positive. Very good. Very good. You're picking up what I'm putting down. 4 quadrants. We broke that down, right? I like to rough rule things. Rough rule is good. Okay? So as I mentioned, the heart sits in quadrant 4. So if I have 0, 90 degrees, I have normal access. If I'm sitting between 90 positive and 180, what side of the heart's on that side? Right or left side? Right. So I have right access. Is that normal? No. So I'm deviating to the right side. If I sit in quadrant 2, that's going towards the what? Left. So if I'm between 0 and negative 90, I have left axis deviation. I'm deviating up there for some reason. We're going to talk why is that so important to identify that. Everybody with me so far? All right. Now, I wish I had a 12 lead. I should have bought a 12 lead. if I had a 12 lead, if you look on your piece of paper on a 12 lead, so when you guys go out there today, tomorrow, whenever you go out and do a 12 lead, anytime you go out and do a 12 lead, we'll call this a 12 lead piece of paper. Right here, you have a split. It's going to say P dash Q R S and then a dash and a T. Everybody with me? And then it's going to give you degrees for this P. Then you're going to get another degrees, 90, and then 20, whatever. You get 3 different numbers. You know why you got 3 different numbers? The first number, degrees, is for the P wave. The second is for the QRS. And then the last is for the T. Everybody with me? All we really care about is the QRS, the middle one. Look at that middle number. If it says positive 40, what does that mean? It's normal, right? Hey, I'll do this for you as well, just so you have a little reference. And we know this is AVF, and lead 1, right? So if I'm 40, I'm around here somewhere, right? So is that normal? Normal access. How about if I had 120, positive 120, or positive 130? Where would that be? Right here, right? So that would be what? Right axis deviation. How about if I had negative 30? Left axis. So that number can tell you right then and there if I got left axis deviation versus right and normal. You can look at that immediately. All right? Now, I'm going to tell you what creates left axis deviation. When you have that, what could it be? Right axis, what could it be? One thing you can see, when you have an MI patient, a patient who's having an MI that's evolving, and I start to treat them, we always question, is our medication treatment working? Well, if I'm ischemic, guess what electricity is going to start to do? Deviate, right? But if I start to perfuse, then guess what electricity will start to do again? Back to the vectors will start going directly. So you can start seeing, as you start to treat your patient, your axis starts to change. It'll start to go normal. If it starts to shoot towards normal, are you doing what you're doing? Is it working? Yes, versus it's deviating even more, then it's not working, or it's increasing. So we're going to learn more about that as I go on to this. So that's one way to identify axis deviation, by using that degree right then and there. P, the QRS, and the T. Look at that number. If you don't have it, that number, you can still identify it by using the 2 leads we've been talking about. What are the 2 leads? AVF and lead 1. So we know this is positive. We know that's negative. We know this is positive. Everybody with me? So if I use lead 1, and we're going to use, put it on the other side, AVF, right? So let's talk about normal axis, quad 4. What should lead 1 be, negative or positive? Positive, right? So my deflection is going to be upright, right? What should my other line be? AVF should be negative or positive? Positive. Upward deflection. Maybe that's not the best looking upward deflection, but upward. Look, normal axis is good. Lead 1, AVF, both what? Upright. Thumbs up, good access. Let's talk about quadrant 3. AVF is going to be what? Lead 1 is going to be what? And what axis is that? Huh? My right hand is down. My left hand is up. That's right axis deviation. Lead 1, right. And lead 1, what's down? My right side. So lead down, that's right axis deviation. Left is up. Let's go to quadrant 2, which is what? Left side. What would lead 1 be? Negative. So who's down now? Left down. Left axis. Right is up. Good. That's quadrant, so that's left axis deviation. So we just figured out 2 ways to figure out right versus left? Using the degrees or using with 2 leads? Very good. Now, if you're out here, which quadrant 1, we call it no man's land, or we call it extreme deviation, lead AVF is going to be what? And so is, they both down, that's extreme. We don't worry about extreme too much. You know why? We don't know how we got there. Most likely you got there via the right side. From here to here, extreme. But you could go from here to here. Do you know? Nope. That's why it's extreme. We don't use that. So we look at left and right. You can get to quadrant 1 from 2 or 3. It's just extreme. So if I know my degrees is above 180 and more than negative 190, it's extreme. I just rough rule. If you want to know the exact deviation, it's actually negative 30 to positive 120. That's the exact axis to be considered normal. But you rough rule it. Rough rule is cool, what we do. So just remember 090, that's fine. But if you're that person that, you know, need to know exact, negative 30 to positive 120 is considered normal deviation. Everybody with me so far? All right. So we move on. So we want to know, okay, what causes right axis deviation? What's going to cause right axis deviation? Right ventricular hypertrophy. What does that hypertrophy mean? Large muscle. A lot of people say, well, damn, that's good. Isn't hypertrophy good? Isn't that a healthy, strong muscle? No, not with the heart. Think about bodybuilders. You ever seen bodybuilders? They got a lot of hypertrophy. All their muscles are huge. How flexible are they? Right? They're stiff. That's exactly what happens to the ventricles when they develop hypertrophy. They become rigid. And guess what they can't do? Contract. They can't contract. They're too rigid. So they lose their flexibility and contractility. And that's what kills a lot of these young athletes. Why? What creates hypertrophy? Work harder, way harder than you should. A bodybuilder, push weights. Push more weights than you're pushing. Add supplements and push even harder. You're pushing more weights, muscle's going to grow. And that's what happens to a lot of these young kids, athletes. They go out there, they do nothing pre-season, off-season. They just hang out, do what they got to do. Then they go pre-season, where they go 0 to 100 because that's what they do. And there's no warm-up to it. They didn't condition their body to be that extreme. So now they went from relaxing all season, or off-season, to now 0 to 100. Their heart is working way above their target heart rate at an extreme level, so the heart's working harder. So what's it growing? Faster. They develop hypertrophy, and that's what they die from. Most of them would die from left ventricular hypertrophy because of that. They got a condition. You never hear people dying during season, because up to season, they what now? Conditioned. Is that pre-season because their body's not ready, is not built for that. So you see right ventricular hypertrophy. It could be acute lung disease, such as a PE. Well, think about it. What does the right side heart pump blood to? Pumps to the lungs. So anything right side is going to be pulmonary disease. So it could be a PE. So if you question, man, sudden onset, difficulty breathing, recent surgery, man, is this a PE? I'm not certain. Do a 12 lead. Do you have right axis deviation? Hell yeah, this is a PE. So you could pick that up. Chronic pulmonary disease. Well, I got chronic pulmonary disease. Is this an exacerbation? Look at the deviation. It'll be significant. As you start to treat, it'll start to decrease a little bit. They live in right axis deviation, but you'll see the number will start to decrease a little bit. Ventricular ectopy, hyperkalemia, that's another one. Sodium channels blocker toxicity. By the way, I don't know if you guys deal with a lot of synthetic drugs such as Molly out here, but Molly, horrible drug. Molly is a sodium channel blockade. It actually locks in the sodium, locks it in. You know what sodium does to the heart? Speeds it up. You lock in that sodium, SVT all day. And guess what's not going to work? Adenosine, calcium channel blockers, none of that works. Why? Because Molly, that synthetic drug, locks in that chemical, it works as a sodium channel blockade. The only thing that works for that is actually sodium bicarb. Why? Sodium bicarb flushes out the channels. That's what it does. So when you flush out the channel, it can start functioning. So how I know that? Well, get a patient who has a synthetic drug. You know, you got a history. Something leads you to the high index of suspicion that they're on some type of synthetic drug. Do a 12 lead. Do a 12 lead. Get a 12 lead. AVR, the forgotten lead. If you have a QRS that's 0.10 or greater with an R prime not all the time, but definitely 0.10 or greater, and SVT, that's a Molly overdose. Give them soda, give them ample sodium bicarb, all of a sudden you see the complex starting to tighten up and the heart rate starts to drop. If you don't, their heart rate will speed up, their complex will widen, and they will die. So we did EDC. We ran out of bicarb. We ran out of bicarb both days. But I can't tell you how many patients we saved by just giving a bicarb because of the Molly. The drug, they take it with everything for some reason. Why people take this, I have no idea. But it's a sodium channel blockade. WPW could cause right axis deviation. You're going to see WPWs in both, right and left. And I'm going to talk about that after I tell you why left. After we talk about left axis deviation. And look at the last bullet. Normal in children or thin adults, especially children. You guys use LifePak 12s? You know what it asks you for every time you hit 12 lead? What's the first thing it asks you for? Age. And why do you want to know the age? Because under the age of 15, it changes your hertz. If you look at that, do a 12 lead under 15, do a 12 lead over 15. Under 15 is going to push your hertz to 150 hertz. What it does, it actually opens up the spectrum, shuts off filters, does at a higher hertz level versus a lower hertz. Lower hertz, like 40, 30 hertz, actually vectors a little bit more so it can filter better with artifact. Why it does that? Because small children at the age of 15 all have right axis deviation. Their right ventricle contracts stronger than their left until after the age of 15. So that's normal for a young kid to have right axis deviation. We expect to see that. If we don't, we have a small kid that doesn't have right axis deviation, I tend to worry. Why is that right ventricle not stronger than the left? Because it normally should be. So they have a high contractility. So we have to look at it from a wider perspective. So we need to do the 50 hertz. That's why your monitor does that. It goes into diagnostic mode. All right. Any questions so far? All right. So left axis deviation. What causes that? Left bundle branch block. We're going to talk about this because we tend to underplay left bundle branch block. That drives me crazy. And I'm going to tell you why. I'm going to really talk about this real plain English, and you're going to see that left bundle branch blocks are very serious. All right, left ventricular hypertrophy. So if I got left axis, that left ventricle is pumping harder than it should. What creates left ventricular hypertrophy? Systemic pressure. If your systemic pressure is higher than normal, that means your heart is contracting harder than it should. It's going to develop hypertrophy. What's another thing that creates right ventricular hypertrophy? Pulmonary hypertension. The pulmonary pressure is so high that that ventricle is trying to pump against that. I don't know if you've ever seen a right ventricle versus a left ventricle. There's not a lot of muscle. So that right ventricle will fail real quick. All right, so pulmonary hypertension is not good. A lot of people say, man, is this cardiogenic? I've seen this, and I've seen this not only in education with my students, but out there in the field as a practitioner, as a paramedic. People struggle identifying cardiogenic. Is this patient cardiogenic? We wait till the patient's in cardiogenic shock before we realize that they were cardiogenic. If I had a patient who's cool, pale, diaphoretic, or ash skin, who has crushing chest pain, rails, with a normal blood pressure, I worry about that, because if this is a cardiac patient, he tells me he has a history of hypertension, he just didn't become healthy today, right before he dies. So his pressure is starting to what? Drop. So you say, damn, is that a normal pressure? Did he take too much meds? I do a 12 lead. Because if I got a 12 lead with right axis deviation, that tells me that the pulmonary pressure is through the roof. But the systemic pressure is trashing, is going down. Now that's cardiogenic. You're going to have high pulmonary pressure, low systemic pressure in a cardiogenic patient. We just wait till the blood pressure drops below 90 before we say, hey, this is a cardiogenic shock. And by that time, he already slipped on the banana. You know, if you would have cut that 12 lead, you would have caught one foot in the grave and the other banana peel. We don't want him to slip. So knowing that, identifying axis deviation helps you out. Inferior wall MIs, ventricular ectopy, pacers, there we go. WPW again. If you notice, you saw it on both, right versus left. So let me simplify this real quick. So this is my heart, by the way, just in case you can't pick out my picture. All right. Then we have a conduction system. All right. SA node, right? Bundle His, bundle branches. Everybody get my picture? AV? All right, that's the picture. I want to draw this heart without the muscle, just the system. The SA node, the intranodal pathway, AV node, bundle His, bundle branches. Everybody get my picture? All right, who's the main pacemaker? SA, right? He works the hardest, right? He sets the pace, 60 to 100. Right? That's why we call him SA. Hold on. Guy's got no sense of humor. All right. Anyway, moving on. So, where's the AV located? Anybody know where it's located?
Right ventricle.
Close.
In between the atrium and ventricle.
Very good. Actually, it's right in the right atrium. Very good. It sits on the floor of the right atrium. That's where the AV is. At the floor of the right atrium. So it's actually supraventricular. It's above the ventricle. So that means the only way that a signal can get to the ventricle is via who? AV. You with me? So if I have a fast heart rate, we give adenosine. Adenosine don't work. We maxed it out. What we think about? Cardizem, right? You guys carry cardizem? Cardizem, right? You know what cardizem is? It's a calcium channel blocker. So, the whole entire conduction system of the heart works off of sodium, potassium pumps, except for, let me use another color. Let's go red, extreme. They all work off the same system except the AV. AV works off of the sodium channels. I'm sorry, they work off of calcium channels. Everybody else works off the sodium channels, sodium potassium channels. So I like to think of it as I-4 on a Sunday at 2:45 in the morning. That's the only time I could think there's no traffic, right? So there's no tolls on the road. So I can go as fast as I want. So when the SA fires off, there's no tolls. So when he sends that signal, lightning speed until it gets to where? The AV. Why? AV doesn't work off the same system. So that's the toll in the road. He doesn't work. He's not influenced by that. And why they're all in the same system? So it can travel lightning speed. Because when the SA fires, it wants to go through the whole intranodal pathway before the muscle even realizes he's been stimulated. And when he realizes he's been stimulated, guess who has the signal? AV. So that means the whole atriums do what at the same time? Contract. And if they contract at the same time, then the force of contractility is significant. Same thing here. Once the AV sends it down, they're on the same system, lightning speed. The ventricles don't even realize they've been stimulated until when? They travel through the whole ventricle. So that means now the whole ventricle at the same time contracts. At the same time, so the strength of contractility is significant. If that signal slowed down or was stopped by something, the ventricles are going to start to stimulate and they're going to start to contract before it makes it to the end. So did the whole ventricle contract at the same time? Nope. So guess what happens to the strength of the contractility? It weakens, decreases cardiac output significantly. Is everybody with me so far? So back to this AV. He works off of calcium channels. Guess who influences him to open? Calcium. When you have calcium, channels open. So the signal comes down. He holds it. Calcium opens the channels. He flies. The signal goes back down. So he's influenced by calcium. The more calcium, the more the channels open. The less calcium, the slower they open. So when I have somebody in AFib, right? Afibrillation, atrial fibrillation. Anybody know what the atrial rate, by the way, is in atrial fibrillation? The atrial rate is anywhere from 300 to 350. That atriums are firing from 300 to 350. Why is my ventricular rate not the same? Because AV could do what to that signal? Block them. He could block them. Does he have to let them all go through? Nope. Why he could block them? Because he doesn't work off of the same system. You with me? So that's why we give calcium channel blockers to AFib. Who influences the AV? Calcium. Block the calcium, channels open up slow. When they open up slow, what happens to rate? Slows down. That's why calcium channel blockers are awesome for AFib, A-flutter. Unless they got WPW. What is WPW? An alternative pathway into the ventricle. Now I have another way to get into the ventricle. We call that the bundle of Kent. It could be on the left or it could be on the right. Either way, whether it's right or left, it's an alternative pathway into the ventricle. That alternative pathway works off of the same system that the whole heart works off of, the sodium channel system. It doesn't work off of calcium channels like the AV. Because it's not like the AV, can the bundle of Kent block a signal? Nope. So if we give calcium channel blockers to a patient who has WPW, you're going to slow the conduction in the AV like calcium channels are supposed to do. But what the heart starts saying is like, hold on a second, you slowing me down here? Hold on, I found an alternative pathway. Boom, he hits this. The problem is he can't block. Once he hits this, he's going to catch the bundle branch. And when he catches the bundle branch, the signal comes up. And then hits the internodal pathway and hits the branch. And guess what happens to my rate? My atrial rate now becomes my ventricular rate. So that AFib patient that we told you that has an atrial rate of 300 to 350, now their ventricle is 300 to 350. How long you think a patient could withstand a ventricular rate of 300? They go right into VFib. Because you did what? Gave a calcium channel blocker to somebody who had WPW. You with me? So, if I have the branch on the left side, guess what kind of axis deviation I will have? Anyone guess? Right or left? Left side. If I had the branch on the right side, guess what kind of axis deviation I will have? Right side axis deviation. So by knowing axis deviation, I'm questioning, do we have his WPW? I can see exactly where that bundle of Kent is, left versus right. But one thing for certain, what are we not going to give that patient? Calcium channel blockers. You know, but you can do whatever you want on your last day of work. All right. Any questions so far? All right, let's get into a little pathophysiology now. We'll speed up a little bit now. Pathophysiology, let's talk about the disease process. This is a healthy heart. We talk about the myocardium. All right, so it gives you a great picture. You know, the coronary system sits on the outside of the heart. It's on actually the outside. So it starts its perfusion from out to the in. So you can see the vessel, the coronary arteries on the outside, and it works its way into the endocardium. And knowing that, that's important to know. I want to identify that because when a heart becomes ischemic, it's going to start the most distal part of that coronary artery, which is what? The endocardium. All right? So the endocardium is always where the problem will start. And then it'll make its way through the myocardium and then to the epicardium. So normal ECG, 12 lead. All right? We look there. How we read a 12 lead, that's why I see a lot of people struggle. If you struggle with 12 lead, keep to the 5 basics. I like to say Felix's 5 basics rules of an ECG. Go to lead 1. Lead 1, the first one up corner. I want to look first, and I want to say, what's my rate and rhythm? Do you know that you could get a 6-second strip on this? Just because I go from lead 1 to AVR to V1 to V4, that's consistent. Count 30 big boxes, that's 6 seconds. They're consistent. Just because there's a break there, it's still a consistent flow. So I can get my rate, and also I can map out, see if it's regular. I can use a 12 lead to do so. All right, so I do that. Next thing I do is I say, are my leads put on correctly? Because at 3 o'clock in the morning, my right becomes his what? Left, and then my left becomes his right. You ever seen that before? We never done that, I know. You can determine on a 12 lead. How? Well, let's go back to my picture right here. I reverse my leads, right? I reverse my leads. So I go to lead 1. My P wave, if I put it backwards, is going to be upside down. And the lead right next to it, which is AVR, AVR sits on the negative side, right? Now, because I switched my lead, is looking at it, this becomes positive, so my AVR P wave is upright. So in lead 1, my P wave's inverted, and AVR, it's upright. Your leads are backwards. You could really confuse somebody. I had a call Portofino Bay in Universal Studios, and actually, bizarrely enough, it was a cardiologist, and his wife was a cardiac surgeon. Bizarre. He syncopized, and they call us to do a 12 lead. So anyway, I was talking over here with the wife. The medic was with the patient. He did a 12 lead. He hands it to me. I look. I say, hey, you got your leads backwards. And he looks. He's like, holy cow, I got them backwards. So he's like, holy shit, this guy can see that far. And he looks at me. I was like, I was messing. I didn't want to tell him that I could read in the ECG. So he looks, and then he does it. So he fixes them. But then he starts walking back to see when he can't read the RA and the LA. And he's like, no lie, about 6 minutes. That was his only focus now. Then after the call, he's like, dude, you got good vision, man. I was like, yeah, I know. And you guys, make fun of me, old man and stuff. I said, yeah, my vision's sharp. He was like, I don't know how you saw that from so far. So I let him ride it a little bit. Then after we got to the station, I was like, look, man, I could see it on the ECG. He's like, oh, man, I was like, man, you sharp vision. But I just looked, what it was is, in lead 1, the P wave was upside down and AVR was upright. Okay? So I always check that because leads got to be on correct. Make sure my calibration, if you look at 12 lead, always starts with this calibration. This right here is for a reason. 2 big boxes tells me it's 1 millivolts, properly calibrated. If it's higher than that, you might mistaken this for LVH, left ventricular hypertrophy, because it'll give you a real peak R wave. Meanwhile, your calibration is just super high. Same thing. If it's just 1 box, it's too low. So check your calibration. Then I go to lead 1. Is my QRS tight or wide? If it's tight, we good. I start reading ST, looking for ST changes. If it's a wide QRS, I go to V1. And if I look to see if it's upward deflection or downward deflection. I'm going to tell you about something real bizarre. It's in your vehicle. It's called signal light thing, majig. So if I want to make a right turn, which way we hit the signal light? Up, right? So if my deflection is upright in V1, then it's right. Right bundle branch block. If it's down, make a left turn, then it's a left bundle branch block, right? Or if you take this ECG I'm looking at and turn it clockwise, which way is your ECG facing? If it's facing towards the left, is left axis. Facing towards the right is right axis, right bundle branch block versus left. You know what I'm talking about? Take the ECG and just turn it, and then you can see. All right, moving on. So ischemia, inadequate tissue perfusion. That's what it is. Where I tell you it always starts at the subendocardium. Starts at the most distal part of that coronary artery. What does it represent by? ST depression or inverted T. What you first going to see is ST depression if you catch it early on. As the MI starts to evolve, your ST segment starts to move upwards. As it starts to move upwards, it looks like an inverted T. What it is my ST segment is pulling back up to the isoelectric line, back to baseline. Both of those are indication of myocardial ischemia, okay? And it may or may not end up in an infarction. It all depends on what we do from here, right? We got to be aggressive when it comes to treatment. So this is a picture of ischemia. So you see the little black dots? That's the ischemia starting to set in at the subendocardium. You know what happens with an MI? I know I'm all over the board. Start right on the walls. That's my same picture of the ventricle. Subendocardium, myocardium, epicardium. Everybody got my picture here? Yeah, a little blood in the ventricle, whatever. All right, coronary arteries. All right. Anyway, it starts here at the subendocardium. This tissue becomes ischemic. When that tissue becomes ischemic, you know what happens to all the good tissue around it? it changes its charge to a negative charge. Because it changed to a negative charge, this electrode is looking at this and it's ST depression. Why? It's a negative charge. All that tissue became negative, so that's what gives you the ST depression. Now, as it starts to evolve, as ischemia starts to evolve, well, let's talk about the pressure a little bit. If you want to know what ST depression looks like, it's right there. I'm way off on my picture, my arrows, but I'm actually trying to point. You see the depression? You see the depression up there? Can you see it? It's identifiable, right? ST depression. As we do nothing for this ischemic, so we talked about it always starts at the subendocardium. All the tissue, the good healthy tissue around becomes negative, which gives us our ST depression look because of negative charges, depression. Now we do nothing about it. It starts to evolve and becomes injured. When it becomes injured from prolonged ischemia, it now becomes transmural. What does transmural mean? That it started at the endocardium and made its way all the way to the epicardium. So who's involved? Everybody. Everybody from the endo all the way to the epi. Everybody with me? When the MI becomes transmural, I now, with my electrode, look to the other side of the tissue. I look at the other side. It's transmural. I can see through. And what is that electrode looking at? The opposite side with the healthy tissue, where is what? Positive. So guess what you're going to see? ST elevation. That's how you get ST elevation. When the MI becomes what? Transmural. The only way you will get ST elevation if the MI is transmural. But for the MI to be transmural, my artery has to have the blockage way before. Because if I had this artery right here and the blockage was right here, is this tissue involved right here? No. But can this tissue right here die? Would it ever become transmural? No. So does it mean I didn't have an MI? No. It just means it was never transmural. So guess what I won't see? ST elevation. That's why never. We should never rule out an MI pre-hospital because of that right there. To consider an MI, to buy a day in the cath lab, you got to have two of the three things. Not all three, just two because of that. What's one? Symptomatic. What's two? ST changes. What's the third? Positive on your cardiac biomarkers such as troponin and CPK. I don't need all three. All I need is two. Can we measure troponin and CPK pre-hospital? No. Then we can never rule out. So if my patient is symptomatic with no ST changes, I take him to the hospital so he can see what? Blood markers. Because if his blood markers become back positive, guess what he had? MI. Was it transmural though? No, but it's an MI. So we should never rule out. They don't even rule out in the hospital. You come in, he's symptomatic, no ST changes, he's staying 24 hours. Why? Because cardiac biomarkers could set in within 6 hours, but could take up to 24. So they're going to keep him for 24. So why are we ruling it out if we don't draw blood markers? Does it make sense? So if he's symptomatic and it seems like it's cardiac and I got no ST change, we just call it a non-STEMI. It's still a cardiac patient. We got to see what his blood work looks like. Okay? So the only way we see an MI, that's a STEMI, is transmural. But not all MIs will be transmural. Is everybody picking up what I'm putting down here? All right, good. So it's represented, when it's transmural, is represented by ST elevation. All right, and then from there, it knocks on whose door? Infarction. Now the tissue starts to die, tissue dies. So, very important, that's what it looks like. See it all the way from the endo to the epi, transmural. I'm going to see ST elevation, that's a STEMI. Because he met the criteria already. What's the criteria? He's symptomatic? Yup. ST elevation? Yup. Do I need biomarkers? No. Because he got 2 to 3. Guess what he's going right to? He's going to cath lab. I'm good. So it's when they don't meet that, they don't have both those two things, then they have to get the biomarkers. I mean, they're going to draw them anyway, but it's not going to stop him from the cath lab. He's going right to the cath lab. We're about biomarkers later because he has two of the three things. Question? Somebody had a question?
Yeah, that one there at the bottom. Like, let's say they did have a heart attack and they didn't know it and they just kept on going on and going on, and then they called whatever 2-3 weeks later, and would you see depression because that's dead muscle?
You won't see depression. Great question. And that happens frequently. Sometimes we could be convincing. You know, that's like sometimes we become the used car salesman, you know, like, don't worry, this is not an MI. Trust me, right here, you buy this right now, you sign the refusal, we're good, done. Take 2 aspirins, take antacid. This, you know, we'll convince them that, you know, we convince ourselves sometimes, damn, this is definitely not MI, you know, and then you convince them, and sometimes it could be because we don't know. But if you're symptomatic, we go. But if some people just ignore it, right? They say the average person waits 60 minutes before they realize they need help, and then they call. And they say the best time to treat a cardiac patient is within the first 60 minutes. So we're already behind the ball when we get there. That's number one. So some people don't call. And when they don't call, you can have a minor MI. But the tissue dies, but everything else is perfused, but that tissue is dead, so they develop no more pain because they have no pain receptors. It's done. Or better yet, they are diabetic. Diabetic, by the way, a diabetic and females are atypical. You know, so what do I mean by that? Is they don't present classically a lot. I think it's 35% of women and diabetics will present atypical. That means that they're not going to present with the classic signs and symptoms of chest pain. Most of the time they complain either shortness of breath or a syncopal episode. Syncope is like a number one of cardiac issues. And what we do with syncope, we write those off. You good. Press hard. It's 4 copies. I'm out. You fainted, really? You know, so if somebody faint and they couldn't tell you the reason why they faint, you know, I was at Halloween Horror Night, somebody said boo. Okay, that makes sense. You know, but we're in January, nobody said boo and you fainted. What's going on? Hold on, let's put them on the monitor. Let's see what's going on. And a lot of times you put them on that monitor, you might see something you don't want to see. That's probably why you don't put them on the monitor. So if you're saying I don't want to put them on the monitor because I might see something, that's the time to put them on. So syncope is common. So when I get that female or that diabetic or worse, the diabetic female, you ain't gonna trick me. I know you're a female and diabetic, and females, they trick us, period, gentlemen. So let's not get tricked. All right, I'll put them on a monitor. I'm gonna convince them, dig deep into what's going on and do a 12 lead and take them to the hospital, because you can't go wrong by doing that. You go wrong by underplaying it, okay? So syncope is big. So they have it. You're not gonna see ST elevation or depression, but you're gonna see what I'm gonna talk about in a minute. It's called a pathological Q wave, all right? So from injury, ST elevation, that's what it looks like. So elevation, can you see here? 2-3 AVF, you see elevation. That's classic right there. That's an inferior wall right there, right? So once the tissue infarcts, dead tissue is dead tissue. And it's going to be represented by that Q wave. It's a pathological Q, all right? And not all the time they would develop it, but what's a pathological Q wave? It could be seen one of 2 ways. Is when that Q wave, this Q wave is 1/3 the size of the R wave. If it's 1/3 the size or greater of that R wave, that's a pathological Q. Or that Q wave is the size of one little box, 0.4 seconds. 1 millivolt, 1 millimeter. If it's 1 millimeter, that's a pathological Q wave or bigger. Okay? That's the definition of pathological Q wave. But all in all, if they have it, oh well. What can you do for dead tissue? Can you revive cardiac muscle? No. Once it dies, guess what? It's dead. So whether that muscle died 2 minutes ago or it died 2 years ago, it's still dead tissue. What can I do for it? Nothing. What's the tissue I'm looking for? Injured tissue. Why? What can I do for injured tissue? Reperfuse. If I reperfuse, I stop the muscle from dying. Do you know how much myocardial muscle of that left ventricle you have to lose before this patient goes into cardiogenic? 20%. 20-30% of that muscle is gone, you're on the LVAD or heart transplant or sick for a long time. 20%. That's not a lot of muscle. When you think about 100% and you're talking about 20, I know 20 and odds in the casino is not good. All right? So you don't need to lose a whole lot of muscle to die. So we have what's called reciprocal changes. What are reciprocal changes? The opposite. Mirror image of what you're looking at. I like to use the ambulance. You ever look in the front of the ambulance, it's spelled backwards. But if you look in the mirror, it's spelled correctly, right? That's what your heart is seeing. When you have an MI, I'm going through looking at the opposite side. I see the elevation. So what's the opposite side of right? What's the opposite side of front? Back. So if my right side is elevated, my left side should be what? Depressed. That's reciprocal. You with me? So let me draw another cool picture right here, because I like to draw and beat up Will's markers. All right. I know he's going to charge me for all these markers. You won't worry, Will. I'll leave the ink on the eraser for you. So, let's go back to my heart. So heart. We have the aorta, and I'm sure I'm drawing it the wrong way, but who cares? Off the aorta, you have the right coronary artery. On the left side of the aorta, who wants to take a guess? The left coronary artery, very good. And then that left coronary artery has two other arteries that branch off it. I call that the left, is on the left side. Descending, that's why the arrow is going down. Left anterior descending artery. And then you have your circumflex. That's the cardiovascular system. That's the coronary system, the major muscles you need. So the right coronary artery comes all the way down the right and to the inferior wall. So if you look right here, what lead is this? 3, AVF, and then lead 2. So that's what part of the wall? Inferior. Who looks at it? These things right here that branch off the right coronary. So the inferior wall is a problem with artery. It's a blockage in the right coronary artery. You know, by the way, the aorta is attached to the left ventricle, right? And then let's pretend the left ventricle is here. I'm not the best artist, I know. But you have the aortic valve right here. You know, when that left ventricle contracts, that aortic valve opens up. Make sense? And when it opens up, guess what it does to your coronary arteries? It blocks them. And then when the left ventricle relaxes, guess what the arteries do? I mean, the aortic valve closes. And when they close, when the ventricle is relaxing, blood just pools into the coronary arteries. That's why we tell you back in EMT school, diastole of a blood pressure is when the heart receives is what? Oxygen. That's why we tell you the diastolic number is so important for a cardiac patient. Because if that diastolic number is high, that means that ventricle is in a state of contractility. So here goes an example. This is an 80 systolic. This is a 90 systolic. This is a 100 systolic, diastolic I should say. So if you notice, I stay in a state of contraction a lot longer than I should. As long as that left ventricle stays in a state of contraction, what happens to the aortic valve? Stays open. He stays open for a longer period of time than he should as the coronary artery is getting blood. That is not getting oxygen. What did I tell you earlier about the consumption of oxygen? It's significant. So by having a high diastolic, patient can have myocardial ischemia. Guess what you can see? ST elevation. Why? Because the heart's ischemic. And it can be caused by what? Just the pressure being so high, that diastolic pressure. That's why it's an important number. Okay, I went off on a tangent. I don't even know why I brought that up. But back to the MI. All right, here we are. Right coronary artery. Left coronary artery supplies blood to the anterior descending and circumflex. All right, so right coronary artery supplies blood to what part of the heart? The inferior. What leads? Look at the inferior part of the heart. 2, 3 AVF. Is this the right side? So guess what's the opposite of right? Left. AVL and lead 1. Directly opposite. So if I got elevation in 2 or 3 AVF, where's my reciprocal changes going to be? AVL, lead 1. Opposite side. I'll show you a picture later. How about if I have elevation in AVL 1, maybe 5 and 6? What's the opposite of left? So where will I see depression? What leads? Inferior leads. You with me? Okay, here we go. This is the big one right here. I have elevation in V1 and V2. That's what part of the heart? Anterior, right? Septal, right? Front of the heart. Where will I see reciprocal? The back, right? Whichever ones you move to the back, right? So that doesn't that mean then, if I have depression in V1 and V2, can that be reciprocal to a posterior wall MI? You won't know unless you do what? A lead in the back. So anytime you have ST depression in V1, V2, you got to say to yourself, is that ischemia? Or can that be reciprocal to a posterior wall MI? The only way you know that if you do what? Move leads to the back. Make sense? Now, the next question I always get, well, why don't they just make a 12 lead with 18 leads? Because it takes too much money to invest. And I'm going to tell you, posterior walls account for less than 3% of all MIs. It's not that frequent that happens. If you ever took out a heart out of a cadaver, all the fat is on the anterior. The heart, back of the heart is no fat. I don't know why, but there's no fat in the back. It's all in the front. So posterior walls are very minor. But if you have ST elevation, V1 and 2, I'll take a look at the back. What leads you move to the back? 5 and 6, huh? All of them, like the limb leads, everything, store everything in the back. Very good. You could use any leads that are your horizontal leads. So your V leads, because they look at the heart horizontally. Your limb leads look at the heart vertically. Can I use a vertical lead to look this way? No. But I could use any leads that look at the heart horizontally to wherever I place them. They go from the Willis Central Terminal to wherever the lead's at. If I put leads to the back, then they start looking at the back muscle. So which ones you want to move? Anyone that's horizontal. Just make sure whatever 3 you decide to move, you mark it on your piece of paper, because the paper is not going to say this was posterior. And if somebody shuffled all your ECGs, how you know which is which? And do you know LifePak 15s? If you put a 12 lead on correctly, do a 12 lead, don't shut it off, leave it on with the for the duration of the patient. If any of his ST segment changes from his first initial one, it automatically prints a 12 lead. So if it prints a 12 lead, means he's recognizing ST changes in your 12 lead, so look at it, okay? If you keep it on. All right, everybody's good with reciprocal changes? Oh shoot, sorry. All right, so you can see here, look at my elevation. 2, 3, AVF. Right side, where's my depression going to be? AVL, lead 1, you see it? AVL, lead 1 is depressed. What does reciprocal changes tell me? Reciprocal changes tell me that this is a true MI, because there's mimics out there. You can have a concave versus convex type of ST segment, and you say, man, is that ST elevation or is that a mimic? Go look for reciprocal changes, because if it's truly an MI, you will have reciprocal changes. If not, you won't. Okay, so that can help you solidify that this is a true MI. So identifying MIs, V1, V2 is just septal wall. Looks right at the septum. All right. 3 and 4 looks at the anterior heart. Lead 1, AVL, 5 and 6 looks at the lateral wall. Right? AVL, 1, V5, V6 looks at the lateral wall, circumflex. So if I had a blockage here, would I get elevation here? If blood's flowing this way? Would I get elevation here? No. So 5 and 6 tells me low lateral. If I have all of them involved, high lateral wall. So I know low versus high by looking at my leads and see where my ST elevation is. All right, which 5 and 6 is low lateral. As I said, 1 in AVL would be a higher lateral. Everybody with me so far? 2-3 AVS is my right. So look, this is what I got, guys. This is a take home right here. This is what you want to write down. If I could find the eraser. Oh, here it goes. Sally. Sally. Anybody heard of Sally? Sally is good people. Sally helps you out. Sally is my cardiologist. All right. Here we go. Sally. Sally stands for septal wall, anterior wall, lateral inferior wall. What's the whole problem? The heart, right? Where's the heart sit? In the chest, right? So let's start with our chest leads. What's the first two chest leads? V1, V2. What comes after V2? V3, V4. What comes after V4? V5, V6. You with me so far? This looks like Roman numeral number what? What comes after Roman numeral number 1? Then? What's the only MI that has an F in it? Inferior. That's just got a puzzle look here. AVF. This looks like a lowercase l. And then AVL. L. Boom. That's it. If I have elevation in V1, V2, what kind of MI is that? If I have elevation 3 or 4, it's a what? Anterior. 5, 6, or 1 AVL, lateral. 2, 3 AVF, left. Or you can even break it down even further, right? Sal and I meaning right coronary artery is the only one involved. The whole sal is left coronary artery. So I have MI in my septal anterior lateral wall, that's my left side. If I have elevation 2, 3 AVF, that's my right coronary artery, right side. So if I have elevation through V1 and V6, what kind of MI is that? V1 through V6. What do we call that? That's called an anterior lateral wall MI, aka widowmaker. AKA widowmaker. Why? Because the blockage is in the upper artery, the left coronary artery. So he's blocking all blood flow to the left side. So whoever his spouse is will become a widow. That's why it's called a widowmaker. All right. So why we always use the anterior first? That's the worst MI you could possibly have. Out of all these MIs, stay away from the anterior. If you have a choice, stay away from that one. All right. Anterior is the worst. The heart uses the anterior muscle to contract. Without that muscle, your heart can't contract. What's the next worst? Inferior. Okay. So if I have V1 through V4, what kind of MI is that? An anterior septal wall. If I have anterior lateral involved, we'll call it anterior lateral wall. And those are the easy ways to remember ST segment. Everybody good with that? How many leads we need to call it MI? 2. Something new. This is something you're going to hear. You talk to a lot of medics like, I haven't heard this, but this is new discovery and evidence, probably in the last year or so. AVR. It's so funny. We call it 12 lead, but we don't use AVR. Why don't we call it 11 lead? You know why we don't use AVR? Because we always taught you, you have to have 2 or more contiguous leads. Who's contiguous to AVR? Nobody. That's why we never used it. But what we've found out, AVR actually is significant. AVR accounts for about 80, if you have ST elevation in AVR, it's probably 80%, 88% chance that the left main coronary artery is blocked. The main artery is blocked if you have AVR elevation. If you have it, it also could be 43% that the left anterior descending could be clogged. Less than 8% is the right coronary artery. Isn't that funny? AVR, we think right. A right involvement accounts for less than 8%. When you have elevation in AVR, you're looking at a left side MI. So if I look at that and if I say, wow, I got elevation in my septal or depression, elevation in my septal anterior and AVR is involved, this is a blockage where? No doubt. Where's this blockage located? Left. This is the guy who got 1 foot in the grave and he's slipping on the banana peel. All right, so AVR is good for that, to determine that. All right. However, ST elevation is in AVR is not entirely specific to left main coronary arteries I talked about. It also coincides with other disease, such as severe triple vessel disease. That means, you know what the three vessels are? Oh, my picture's gone. Shoot, I'll draw a little heart here. This vessel, left coronary artery, the descending, and the circumflex. That's the triple disease. All right? So it could be the left anterior descending and then deal with more diffusion of the little arteries that branch off the subendocardial that creates ischemia. All right, moving on. I'm almost done, guys. I know it's a lot of information. Scarbosa. This is really, I want this to be take-home information for you. This is something that you need to take home. Mimetics. Scarbosa. Dr. Scarbosa created this criteria because for many years, many years, we said if you had an old left bundle branch block or ventricular pacer, that was a mimic. I couldn't call it an MI. I couldn't call it a STEMI. We could say he's a cardiac patient, still take him to a cardiac, but we couldn't call a STEMI because it was old. If it was a new left bundle branch block, yeah, that's a STEMI. That no longer, that's a thing, that's a historical piece of information because of Scarbosa. Dr. Scarbosa says, no, that's false. He says if you meet this criteria with the old bundle branch block, he's a STEMI. So if it's a new left bundle branch block, I don't need Dr. Scarbosa's criteria. It's automatically a STEMI. Everybody with me on that, right? New onset left bundle branch block, STEMI. Scotty, beam me up. Star Trek? All right, whatever. All right, so Dr. Scarbosa came with this criteria. He says if you meet any one of these three, he's a STEMI. For what patients? I want to reiterate. For the ventricular pacer patient and the left bundle branch block patient. Those are the two patients this pertains to. So if I have ST elevation of 1 millimeter or more and it's concordant, that's a STEMI. I'm going to talk about what that means. I just want to read this real quick. ST depression, 1 millimeter or more, V1, V2, V3, that's concordant. That's also a STEMI. ST elevation with 5 millimeters is discordant, is considered a STEMI. That one hasn't been validated yet. So let me just talk about these. Let me talk about what this means. We're going to go through this so you understand the points and the validations. Real simple, real basic. Can I erase this right here, guys? All right. I'm going to take that as a yes. We use, for Dr. Scarbosa's criteria, we use two simple things, concordant and discordant. What does that mean? Concordant means same side. Discordant means the opposite sides. Okay? So what do we use to measure MIs? What are we looking for? What part of QRS we use? ST segments. So we're using the same thing. So we look at the ST segment and we look at the QRS. If my ST segment and my QRS are on the same side, we call that concordant. You with me? If my ST segment is on one side and my QRS is on another side, we call that discordant. So what would you call this, guys? Concordant, because I have my isoelectric line. Is my ST segment above? Is my QRS above? Since we're on the both on the same side, we call that concordant. How about this? Concordant, very good. Why? Is my ST segment and the QRS on the same side? It's still concordant. It's just below the isoelectric line, but we're both on the same side. So it's concordant. Versus, I have to think about my picture real quick. So my ST segment is high, but most of my QRS is where? Opposite. So are we on two different sides? Actually, it should be the other way around. I'm discordant. That's what I meant to do. So, are we on opposite sides? So it's discordant. So Dr. Scarbosa says, if I have a left bundle branch block and I have concordant of just 1 millimeter, which is one little box or more, or a left ventricular pacer that is concordant, that's a STEMI. You call it. I got a patient with a bundle branch block that's showing that meets the Scarbosa criteria. It's a STEMI. Once you say that, doc knows exactly what you're talking about. All right? And this has been around for a very long time. Actually, that's the sad part. I remember when it first came out, I called one in and the doc says, in the ER, he was like, shit, man, you act like you know what you're talking about. And you say it with a lot of confidence. I never heard of it, but I'm calling the cardiologist. And he kept the STEMI. He was like, wait, call the STEMI. He was like, shit, you sound like you know what you're talking about. And then the cardiologist says, yes, that's a new criteria that came out that was studied, and the evidence showed that this is what it is. So if I want to reiterate, if I have a left bundle branch block or a ventricular pacer and it's old, they have a history, I look for this. If they meet any one of these three, you call it a STEMI. Is everybody with me? Does everybody understand that? So where your bundle branches sit, sits in the septum. What leads look at the septum? V1 through V3. So if I have this in V1 through V3, I call that a STEMI if I have any one of these three. That's what I'm looking at. I'm looking at V1 or V3 to see if I have concordant or disconcordant, whether it's above the isoelectric line, below, or on the opposite. Is everybody with me? Now, they modified Scarbosa's criteria. They modified it to validate it. They were able to validate. They said it does happen with left bundle branch blocks and ventricular pacers, what we talked about. This is what they were saying. They're saying that the concordant on the same above the isoelectric line and the concordant below the isoelectric line, 100% validated. They say if you have any one of those, 90% chance of an MI. 90% chance you have an occlusion. That's high numbers. That's almost 100%. The disconcordant hasn't been validated. It's been proposed, but hasn't been validated. And what they proposed from the information, they're waiting for validation. It's a 50% chance if you have disconcordant. But shit, 50% chance on the in Vegas, I like those odds, right? So in other words, if I'm your patient and I have a left bundle branch block and you see disconcordant, call a STEMI. You have a 50% chance being right. Let's favor on my side. All right, not the cardiologist. So I'm calling a STEMI regardless. But that's 50%. You might get the ER doc, kick back a little bit. I want to share a quick story. I don't like to jump a lot of stories, but this was a good one. And this was here at ORMC quite a few years ago. And I want to share this to show you how we have to advocate for our patients. I had a patient I picked up at Bonefish Grill up by the airport. That's about a 20-minute drive to ORMC. It was a lady. It was a cardiac patient. All she had was a syncopal episode. We got there, did a 12 lead, boom, she had ST elevation, the whole 9 yards. Only complaint, she syncopized, pale skin. Did a 12 lead, STEMI. Took her to ORMC, started the reperfusion. The time I got to ORMC, no elevation whatsoever. Patient pinked up, good, everything. It was perfect. It was like I was lying. So we roll up there, I call the STEMI, we roll up there, and I happened to be doing a study. I'm the one who published that whole PIC crew study of doing the PIC crew cardiac arrest. I did that with Dr. Silvestri and Dr. Hunter. We did it at my school, and also Dr. Vu, who happened to be the doc there at the ED. He was a third-year resident. So we pull up, and I was like, oh, Dr. Vu, STEMI. He looks, patient's looking fine. He's consulting with the attending, and they're talking, but they haven't called the STEMI yet. I called it. So I hear them talking, but I really couldn't hear what they were saying, so I'm cleaning my stretcher, wheeling it over so I could be nosy. So I roll over and clean it, and I'm listening. Now I hear say, yeah, you think we should call her? Nah, she looks good. You know, let's just watch her, you know? So I was like, hey, Dr. Vu, I can't help but overhear your conversation. You're not going to call this a STEMI? He was like, no, we're not going to call it a STEMI. I said, this lady is having an MI. He was like, oh, Felix, get out of here. I was like, no, serious. I said, look, you know, I had an ECG that showed ST elevation, 2 or more contiguous leads. I started the reperfusion because I was aggressive. It could be that maybe the reperfusion is what's allowing her to be asymptomatic. She is a female as well, which counts for 35% of atypical patients. He was like, and the other doc was like, who is this paramedic telling you what you should do? And he was like, no, I know him. He's, you know, I work with him. We're doing a study. He was like, Felix, man, get out of here. So I was like, all right, I'm just saying, and I'm supposed to advocate for my patient, right? You know, saying all this, walking out, and I came back. I said, look, Dr. Fu, I can't leave this ER. He was like, I was like, this patient is having an MI. I said, look, he was like, look, I'm not going to call you. I said, look, okay, cool, no problem. You don't want to call it? Understood. I said, Dr. Vu, no disrespect whatsoever I'm about to say. I know you, Chris, we're great. No disrespect. I know you've been doing this 3 years. I'm on my 25th year. Gut feeling. If you don't want to call it based on that, Call it on my gut feeling. 25 years of experience. You're going to let walk out the door and have this gut feeling, advocate for my patient. I'm out of here. And I walked out. Came out, the tech came out and said, Dr. Vu said, give him a copy of your 12 lead. If it shows ST elevation, he'll call it. He said, your gut feeling better be right. So I ripped it off, went inside. I was like, hey, he was like, that was really bullshit what you just said with the whole gut thing. And you're 25 years, I want to call that is bullshit that you said that. I'm going to do it based on that. He says, Felix, if this lady's not having an MI, I swear to God, I'll be at your school next week. I said, I'll never come back to ORMC. Promise. So anyway, left it alone. I left, totally forgot about this patient after that. So we finishing up this project. He comes back to my school 2 weeks later. He's like, hey man, remember that lady that you were being a real a-hole with? He was sharing that language with me. And I was like, yeah. He was like 98% blockage of a circumflex and about 70-something% in her left anterior descending. He was like, good call and advocate. He's like, man, lesson learned from me. You know what I should do? Listen to what the medics tell me. He's like, if you didn't advocate for that, I was gonna let that lady sit there and probably even have more muscle damage. So that's advocating for your patient. I saw the ST elevation. I know what I was looking at. I start the reperfusion. I understand how pathophysiology works. I understand electrophysiology. They just didn't want to hear what I had to say. Why? They were looking at 100% what? The patient. We do that all the time, right? Hey, you look fine. I hear the story, but I see you. Nah, you're BSing. This is what it is. And sometimes you have to look at both. Is what I'm saying, the moral of my story. So, moving on. So, ST elevation, concordant, we talked about that. ST elevation, concordant, below the isoelectric line, concordant, STEMI. If it's discordant has to be 5 millimeters or more. Compared to concordant, all it needs to be is 1 millimeter. So when you have discordant, let's look to confirm that it's 5 millimeters or more of elevation on the opposite side. If it's not, but it's close, let's say maybe it's 3, it's 4, I'm going to do serial 12 leads to see if it increases. Once it hit 5, I'm going to call it. So because of the Scarbosa criteria, as I mentioned, it's concordant. It's specific to, I said 90% of patients are having an MI. Those are good odds. All right, left bundle branch block. We're winding down, guys. Left bundle branch block versus right. You're going to have, we talked about that, right? YQRS and lead 1, go to V1. Remember I said turn the ECG? So if you turn it, if it's facing to the right side, it's a right bundle branch. Left bundle branch. We call it the 90 degrees. So take your ECG and just turn it. Look at V1. If the ECG is pointing that way, it's a right bundle branch block. If it's pointing that way, it's a left. This is the take home here. This what drives me crazy when we don't look at these bundle branch blocks as serious, especially if it's one of my loved ones. I want you to know that left bundle branch block can mimic ACS, acute coronary syndrome. It could hide evidence of ACS. 60 to 70% association, left bundle branch block, 60 to 70% of left bundle branch blocks associates with pump failure. Cardiogenic is what we're talking about. And we say 40 to 60% will die. The mortality without reperfusion, die. We're talking a left bundle branch block. Think about it. What's the left bundle branch do? Stimulates the muscle of the left side to what? Contract. What did I tell you earlier about electrophysiology? If anything disrupts that electricity, the muscle starts to contract before the whole muscle is stimulated. So it weakens the contractility. When you have a left bundle branch block, that's my right, that's my left, and the blocks here, electricity can't go down. All the electricity comes down the right side, then it starts to move through the septal wall to catch the branch, slows the signal down, disrupts the electricity of the flow of the heart, decreases the contractility. These patients could die. So, you know what? It may produce ST elevation, may produce ST depression, may produce a tall T wave, may invert a T wave, have a YQRS. It may hide ST elevation, may hide ST. They're the same thing. So what am I trying to tell you in this slide? Don't bank on looking for ST elevation on left bundle branch block. Get the history, look for Dr. Scarbosa's criteria, or if it's a new onset, no brainer. It's a STEMI. Think about how many people would die if this is a new onset or if they actually have an MI with left ventricular involvement. from the bundle branch block. So you go to lead 1. Is that QRS wide? Go to V1, down or upwards? Down. So what is it? So if I took this ECG and turned it clockwise, which way is my ECGs facing? Left. Left bundle branch block. Left ventricular hypertrophy. I don't know. I think there was a lot of grant money when it came up with left ventricular hypertrophy. Hey, can we find a way to identify left ventricular hypertrophy? And everybody came up with one. Everybody. Look at all these ways to read it. They're bizarre. I'm going to teach you the easy one. But look at this one, right? Cornell is probably one of the most common, but add the R wave in the AVL and then the S wave in V3. If it sums up to greater than 20% in male or 20 millimeters in females, you have LVH. It's crazy. Who remembers that? So they said that's a little crazy, extreme. Let's modify it. Just take that R wave in AVL. If the R wave is 12 millimeters or more, you have LVH. That's a little more easy, right? Go to AVL, count how many little boxes is in. You could do that. They came up, so look right here. So you go to AVL, you can count those little boxes, but as you get older, those little boxes become dots. And after you get to the third one, you can't see the fourth or fifth. You're back to counting 1, you know, and you screwed up. Then you go ahead, and then you got to do something like I got to do. Hey, do me a favor, hold that ECG up so I can read it, right? Got to put it real far. So, easy way to do it is you go to V5. V5, why? V5 looks directly at the left ventricle. Look at that R wave. If that R wave is touching 5 big boxes or more, you got LVH with a slope S. See how the S slopes down? If you have that slope S and that R wave is touching 5 big boxes or more V5, you got LVH. You got left ventricular hypertrophy. Let's use the big boxes. Let's stay away from the little ones. Early repolarization. Early repolarization, check this out, guys. Early repolarization, common in people under 50. All right? Common on people under 50. Less common people over 50. Rare over 70. So if I got that 70-year-old that has ST elevation, am I really debating, is this early repo or an MI? Most likely is what? MI. Let me go look for reciprocal changes to confirm. Less than 50, the young people, they have early repo all the time. So what is early repo? Here you go. Real simple, real easy. You're going to have a concave ST elevation really in your V2 to V5 leads. But there's not going to be no reciprocal changes. No reciprocal changes. This is what you're going to have. So it's concave, meaning it's caved in versus convex, over, right? Concaved. Convex. See the difference? If that doesn't work, pretend you had a beer. If I pour the beer right here, what would it stay? Inside. All right, it's concave. If I poured it here, we lose the beer. It's no good. It's no good you lose the beer. Neither is an MI. So, convex MI, concave early repo. You with me? And if I'm not certain, what am I looking for? To confirm reciprocal changes. Where? Opposite side. Or you could draw a happy face. Yup, concaved. You could see the fish hook, right, on top. Those are just different things you can look for early repo. You know where you're going to see these at? Who's repolarizing early? Your ventricles. So what leads, look at the ventricles, these right here. 3, 4, 5, 6. And once again, guess what we're not going to have? Reciprocal changes. All right? A lot of times you'll see it goes like this. Comes up, comes back down, goes back up, then concaves. So you have that S segment. Compared to true ST elevation, you don't have that. So look for that as well. And you'll see it more in your V2, V3, V4, V5 leads. Pericarditis often occurs after a respiratory infection. You know what's the number one thing that leads to pericarditis? The flu. Chest cold infection spreads around the pericardial sac, creates inflammation, Boom, pericarditis. You know how you know the patient has pericarditis? When you grab that 12 lead and you be like, whoa, this guy is having a septal anterior lateral inferior wall MI. No way. If you find yourself saying that, it's probably pericarditis. All right, because guess what the ST elevation is? All over. All over the place. When I see ST elevation all over the place, I say, hey, you've been sick with a respiratory infection. Oh my God, I had the flu. How do you know? Pericarditis is showing me. 12 lead is showing me. All right? Look at this right here. You got to say, damn, that ain't good. Yeah, because you got pericarditis. But you know you're not going to have? Reciprocal changes. And a lot of your ST segments are concave too. Just like early repo. They're concave. They're not convex. So you know you got pericarditis. Brugada. This Brugada syndrome is two doctors. They're two brothers. Dr. Brugada. I think they were Colombian. So Brugada syndrome is a syndrome you don't know about. You know when you're going to know they got Brugada? When they're dead. Unfortunately, Brugada is horrible. Brugada is a problem. It's a problem with your sodium channels. All right? It's an abnormality that puts you right into VFib. You know what's the common problem? You might pick up a good medic might say, or even a good doc might say, oh my God, this guy has Brugada. A syncope episode can't determine why. What did I tell you should do with syncope episodes? 12 lead. Do a 12 lead. Syncope is the most common thing to Brugada. If a patient has Brugada, this guy has one foot in the grave and he is slipping on the other. That banana peel, gone. All right? These patients code right into cardiac arrest. They look at their coronary arteries, everything is fine. Clear. Crystal clear, but they died of a heart condition and it's Brugada. How you find it? Look in your V1, V2 leads. You see that slope? Goes up, slopes right down, like a ramp. Like a ramp. See the slope? Can you see him? If I had a patient who has that slope and complain of a syncope episode, Scotty, beat me up. I'm taking them to the hospital quickly. This patient is circling the drain. They're lucky they had a syncope episode and was able to call 911. Because guess what the symptoms they have? None. They just die. They go right into VFib. And it's a sodium channel deficiency. Ventricular pacers. If I have a pacemaker, can I have a heart attack? It don't automatically say you got a ventricular pacer. You're prone from having MIs. You're most likely going to have an MI. But then we say, oh, yeah, it's ventricular pacer. He's good. Sign of refusal. So why? He's Coupel diaphoretic. So ventricular pacers have MIs as well. What can you use to determine if it's a true MI with a ventricular pacer? Scarbosa. All right, guys. Any questions? I know it's a lot of information, right? But read up on your information, man. It's good stuff. Any questions for me? No questions? This is a good group of class. You have no questions. I love that. Yeah, all right. Damn it. You got to ruin it.
Can we get that slide?
Can you get that slide? Absolutely. I'll send it to Will. And then he could put it out however you want to put it. And they recorded it, so I don't know what they're going to do with the record, but just make sure you bleep out all the bad stuff if I say anything. You know, normally I say some more stuff, but I know on the camera, I see the cameras remind me, Felix, don't say what you want to say right now. I'm a fireman. I can only be serious 40 minutes at a time, so